Good evening, everyone. I'm Dr. Kalkitan, your moderator for today's session. It's a pleasure to welcome you to the part 2 of our webinar series on pediatric dental trauma. So our goal today is not to just listen, but we'll engage, learn, and reflect on the evolving landscapes of pediatric dentistry. So thank you all for joining us today. And it is my absolute pleasure to introduce our distinguished speaker, Dr. Dina Rabea. Dr. Dina is a pediatric dentistry specialist with an extensive clinical and academic experiences. She holds a master and is currently completing her PhD in pediatric dentistry at Cairo University. She also serves as an assistant lecturer at the Egyptian Russian University and has lectured internationally, including very big major pediatric dentistry congresses. She is also an active researcher, a reviewer for international journals, and is a recognized leader in public health innovation named a Global Change Ambassador for EcoChange. And today we're very fortunate to benefit from her insights grounded in clinical experiences, enriched by international collaborations, and deeply committed to improving children's oral health. So our today's topic session would be the part 2 series of emergency management for traumatic dental injuries in pediatrics, and we'll be covering critical strategies for immediate and effective response to dental trauma in children. We expect practical insights, clinical pearls, and guidance on improving dental emergency care outcomes. So before we begin, I'd like to give you a few quick housekeeping notes. So the main lecture will be running from the duration necessary to cover the material thoroughly. And following the lecture, we'll be proceeding to our Q&A session. Please type your questions in the Zoom chat box, and I'll be reading them out loud to Dr. Dina to respond them one by one. If you have any concerns, technical issues during the webinar, please feel free to message in the Zoom chat box. And please note that this session is being recorded. And to ensure you receive your certification of participation, make sure you rename your Zoom devices to your actual full name. So please join me in welcoming Dr. Dina Rabea. Dr. Dina, the floor is yours. Thank you.
Thank you, Dr. Elkidan, for the introduction. Thank you so much. So I'm very happy to meet you all again, and I'd like to extend my thanks to everybody who's listening and dedicate this session to my professor, Professor Nurhan Al-Dou'i, who is probably listening to me right now. She's one of the most eminent professors of pediatric dentistry in Egypt and Cairo University, and also in the Egyptian Russian University. She is the head of the department. So let's start with part 2 of emergency management for traumatic dental injuries. In this part, we will be specifically discussing how to treat and manage permanent teeth when we face dental traumatic injuries. I'll be starting with fractures and dedicating the other part of the lecture to the luxative injuries management. And again, all the guidelines are from the American Academy of Pediatric Dentistry 2025, the latest update. So let's start with fractures and enamel infraction. Infraction is not actually a complete fracture. It is a crack or an incomplete fracture in the enamel of the tooth. This is considered a type of mild kinds of fractures. Sensitivity to percussion is usually not present, and usually all the kind of trauma that is not relevant to the periodontal ligament injury will not cause sensitivity upon percussion. Also, mobility is normal. Pulp sensitivity is positive, the pulp is alive, and upon radiographic investigations, we would like to see one parallel per epic radiograph for this kind of fracture. And maybe if other signs of potential injuries accompany this mild fracture, we would like to see an additional radiograph according to the case. Upon follow-up, clinical and radiographic follow-up, it's usually very mild. We do not need to see any kind of follow-up unless, again, there is some kind of accompanying fracture or luxation injury to this infraction. Again, for the treatment, it's very mild, so usually we do not need to do a treatment, or if there's some kind of sensitivity to drinking, breathing, eating some sweets or so, we can seal the enamel with composite resin. So this is one of the mildest trauma we're going to discuss. Let's proceed with the second kind of fractures, which is the uncomplicated crown fractures in enamel. So uncomplicated crown fractures are fractures that do not involve the pulp in the fracture. Sensitivity to percussion, again, as long as the periodontal ligament is spared, we do not have any kind of sensitivity to percussion. Mobility is normal in this kind of fracture. The pulp sensitivity is positive, and for the radiographic investigations, we would like to see one parallel periapical radiograph, and this is usually our baseline radiograph. And we can use additional ones, again, in the case of accompanying injuries or luxations. When we have a fragment of tooth that is lost, we would like, again, to search for this fragment. It might be, again, on the floor with the parents, and these are good scenarios, ingested in the digestive system, and this is still not a very bad scenario, or aspired, and this is the worst scenario that needs to perform a chest X-ray in this case. So also we need to check the lips, the cheeks, the tongue, the soft tissue, to rule out that the fragment might be embedded in these tissues upon falling or upon the trauma. Clinical and radiographic follow-up. We might need to do some clinical and radiographic follow-up, maybe after 6 to 8 weeks for the first time, and after 1 year to make sure everything's going on okay. For the treatment, usually it's a very mild fracture, so we might need only to smoothen the edges of the enamel. If it's a bigger lost part of the tooth, we might need to do some composite restoration and bond it using universal bond or any kind of I would like to ask whoever using the annotations to just clear it and okay. So when it comes to the next type of fracture, which is the uncomplicated crown fractures in enamel and dentine. So this is, again, a mild fracture, but we have a more extensive part involving the dentine, deeper fracture. Probably the fragment, again, we have to search for it. We have to search in the soft tissue, the lips, the cheeks, the tongue, radiograph, in case we feel upon palpation any kind of irregularities. We have to rule out that the fragment is lost, ingested, aspired, or if it is with the parents, this is the best scenario. We can reattach the fragment after rehydrating it, because most of the time after leaving the fragment in a dry media, it gets so dry. So most of the time we need to rehydrate it with saline, with water, to have the same color matching with the tooth upon bonding. Again, no sensitivity to percussion as long as the periodontal ligament is spared. Mobility is normal, pulp sensitivity is positive. It's the same as the earlier fracture, and the follow-up again is usually 6 to 8 weeks for the first time, and we can see the patient again after 1 year. When we proceed to complicated crown fractures, which are fractures involving the pulp, we have to start thinking about the prognosis of these kinds of fractures, because once the pulp is involved in the story, you have to think about so many scenarios. Will it survive? Will it go necrotic? Will it, in case the tooth is with an open apex or an immature tooth, will the tooth revascularize for the part for the fractured part? Will the tooth get necrotized after some time? So you have to think about a lot of scenarios. Most of the time, there is no sensitivity to percussion. Mobility is normal, and for an exposed pulp, the pulp is, of course, sensitive to the stimuli. So for the radiographs, we ask for the parallel baseline radiograph, the periapical radiograph, and we ask again for an additional one in case there are some kind of other potential injuries, and we search for the fragment in case we can see any irregularities in the soft tissue like the lips or the cheeks. The treatment usually is in permanent dentition is usually achieving a partial pulpotomy and covering the dentine with a gloss ionomer or composite. In case the fragment is with the parents, you can rehydrate it and reattach it after performing pulp therapy. We need more follow-up in this case scenario because of the pulpal involvement. So we'll start to see the patient after 6 to 8 weeks, then 3 months, then 6 months, then again after 1 year. So we mentioned infraction in enamel fracture, enamel dentine fracture, enamel dentine pulp fracture, which is the complicated crown fracture. And now let's proceed to a more severe type of fracture, which is the crown root fracture. And again, crown root fractures are either complicated or uncomplicated. Uncomplicated crown root fractures, the cementum is involved for the first time. There is an extension of the fracture line below the gingival margin. And for the first time, we mentioned tenderness upon percussion because the periodontal ligament in the root part or in the fractured root part are involved. Most of the time, you get the patient with the fragment in situ, but with high mobility. Due to the root attachment, the fragment do not separate completely, but it is mobile. And again, we have a hazard of mobility when the patient is young. We consider the risk of aspiration. Pulp sensitivity, again, is positive. The pulp most of the time is positive because this does not involve the pulp damage with any limits. For the radiographic investigations, we'll start to ask for more than the baseline periapical parallel radiograph. We would like to see 2 additional radiographs at different angulations. Sometimes we have to check the fracture line is actually not embedding on the pulp. Sometimes it is passing by the pulp, but we cannot see it due to an angulation. So we'll have to take a different radiograph from a different angulation to make sure the pulp is saved. We might want to check an occlusive radiograph as well. And if we have a separated fragment, which is not very likely in this scenario, we have to search for it again in the 4 places plus the soft tissue. And in all fractures involving the roots, we might want to see a cone beam CT, CBCT, in cases we cannot diagnose enough from other mentioned radiographic investigations. In case the CBCT will not provide us with more data that will change the diagnosis, so the guidelines suggest we do not take this CBCT and prevent the patient from this hazardous dose. CBCT can provide us with the fracture extent, the path of the fracture line, and the relationship of the fracture line to the marginal bone. Also, when we talk about immaturities, we have short roots. Most of the time, we have to inspect how short is the root. Is it enough for root canal treatment? For example, if we're talking about complicated root fractures, if the tooth is very short, we have to extract it. Sometimes it's very short, very immature, that we do not take the risk for putting some kind of restoration over this tooth. We are going to discuss this later. the treatment in this scenario is the removal of the mobile coronal fragment and covering the unexposed pulp, the dentine, with glass ionomer or composite. Future treatments for this kind of teeth, in the future, you might have to extrude the tooth orthodontically or surgically in case you cannot perform complete isolation or a well-sealed restoration. Also, sometimes necrosis of the pulp, even if the pulp is not evolved, sometimes these kind of fractures, they are very severe. Sometimes the periodontal ligament damage can cause a pulpal damage as a sequelae, so we might need to follow up the pulp more commonly than other mild fractures for 1 week, for 6 to 8 weeks, for 3-6 months, and for 1 year. And this will be the routine for all the upcoming fractures because most of them are very severe fractures, and the luxations, they affect the periodontal ligament, the prognosis of the root, and so on. So sometimes we have to check if the pulp is getting necrotized. We can see this through clinical signs and symptoms, as mentioned before, like fistula, abscesses, pain on percussion, persistent pain on percussion, and so on. We might want to extract very short roots, as I mentioned earlier. And autotransplantation, this is a very high P treatment for these kinds of teeth. When we lose these kinds of teeth, for example, for complicated crown fractures, severe extrusions, or lateral luxations, also for avulsions, sometimes we can apply autotransplantation, which is using another tooth, another immature tooth of the same patient, for example, like a premolar that is of less aesthetic value, and bring this tooth to the fracture location and implant it and let it complete its root maturation. Excuse me. And this saved the patient the risk of using an implant. And of course, the implant gets affected most of the time with the direction of the growth of the maxilla at this very young age category. And also, it's the tooth of the patient most of the time. Success is expected in these cases. We can later on reframe the tooth, reshape it. A premolar, for example, we can remove the palatal cusp gradually to prevent exposure of the pulp. And in these cases, we need most of the time to apply a root canal treatment for the autotransplanted teeth after 2 weeks of splinting. And autotransplantation is a valid option in most of the upcoming fractures to be discussed. But again, it's a new treatment. It's a high treatment. It needs planning. It needs a consent from the patient side, from the parents. It needs the designing of a 3D model of the tooth to be transplanted to make sure that the socket, the bone height at the anterior aesthetic zone is enough, and so on. It needs a lot of preparation. It needs a surgeon in cooperation. And I'd send you to watch a lot of cases documented by Professor Monty Dogal and his team in autotransplantation in traumatic dental injury cases, Dr. Hani Nazzal too. Very interesting cases. They do it and they are following up for a very long time. So let's proceed to the complicated crown root fractures. So this is the exact same of the earlier fracture, but with the involvement of the pulp. It is a fracture in the enamel dentine together with cementum, but also we have a pulpal exposure, and there is an extension, of course, of the fracture line below the gingival margin, and this is what makes this fracture very difficult, again, to restore. Because most of the time we have a lot of blood in the subperiosteal region. You cannot restore without maybe extruding again orthodontically, surgically. Surgical extrusion, you need to do RCT or root canal treatment after surgical extrusion, because most of the time it's a very aggressive procedure, just as you are extracting the tooth. Sometimes it's very difficult to isolate and treat the teeth. Again, we need a very long follow-up schedule for this kind of fractures, 1 week, 6 to 8 weeks, 3 months, 6 months, 1 year. And then we have to see the tooth yearly for at least 5 years to make sure pulp necrosis, if we do not carry on RCT, is not happening. And this is possible only most of the time in the immature teeth due to the very wide epices that allows blood supply to revascularize the teeth. And again, the radiographic investigation is the same as that in uncomplicated crown root fractures. We start with the baseline parallel periapical radiograph. Then we might take 2 additional radiographs at different angulations to make sure we see the fracture line. We might need an occlusal radiograph. We might want to check for the fragment in case it is not attached in the socket. And again, this is not very common in this kind of deep fractures. And CBCT is a valid option in case it's going to add to your diagnosis or change it completely. The treatment in complicated crown root fractures, in immature teeth, we have to preserve the pulp with partial pulpotomy. And most of the time in immature teeth, our aim in this kind of traumas is to save the vitality of the pulp so that we can have the maturation of the root complete. In mature teeth, it's very difficult to preserve the vitality as mentioned earlier. So most of the time we have to remove the pulp and then restore the tooth in both scenarios with glass ionomer or composite. Again, we can discuss the future treatments for this kind of teeth, but these are dependable upon the age of the patient, their cooperation. Again, we can do complete RCT, root canal treatment, ortho or surgical extrusion. Root submergence is some kind of a treatment that avoids getting ankylosis in these traumatized teeth, and it's very valid also in intrusion cases because it spares the periodontal ligament at the cervix, and these are the cells responsible for causing ankylosis at growing phase of the patients. This is very difficult to overcome at this age category due to the fact that the fast growth of the bone allows the ankylosed tooth to get submerged in a vertical dimension and lose both the vertical and the horizontal bone thickness. So most of the time, it's better to submerge the root to avoid losing the thickness of the bone, because when you have to choose between the bone and the root, you have to choose the bone. The bone is much more valuable than a root of a tooth. And then in the future, we can use an implant for this kid in case we have enough bone saved from this procedure. Also, extraction is always an option, but this is the last option because we're speaking an aesthetic zone, a very important aesthetic zone, and auto-transplantation as discussed earlier. So let's proceed to the last kind of fracture. We have discussed enamel fractures, enamel dentine fractures, complicated enamel dentine fractures, crown root fractures, complicated and uncomplicated, and now we are discussing root fractures. And the last fracture is the alveolar fracture that I also tell you, I think it's beyond the capabilities of a pediatric dentistry alone. Root fractures in permanent dentition the prognosis depends mainly on where the fracture line is. An apical root fracture has much better prognosis, for example, than a cervical root fracture, because when the fragment gets closer to the point of force application to the cervix of the tooth, excuse me, it gets very difficult to get this fragment to stay in place, even with a splint. So most of the time, if you have a deeper fracture line, you expect a better prognosis for the teeth. So apical and middle root fractures show better prognosis than cervical root fractures. And that's why when we treat these cases, we suggest that we splint the root fractures in the case of apical and middle root fractures for 4 weeks, for example. But when we talk cervical root fracture, we suggest, the guidelines suggest 4 weeks to 4 months. Excuse me for a second. Of course, with root fractures, we get sensitivity to percussion because we have inflamed periodontal ligaments. Most of the time, with the apical and middle root fractures, the coronal fragment is not very mobile, but with most of the upper middle root fractures and cervical root fractures, we get a lot of mobility and bleeding from the sulci, from the gingival sulci. Root fractures might cause a transient negative pulp sensitivity testing indicated because of the cut caused to the periodontium. Sometimes it's transient, sometimes it's forever. It's a permanent damage. The radiographic investigations are the same as the complicated and uncomplicated crown root fractures. And when we speak clinical and radiographic follow-up, again, we would like to see the patient at 4 weeks to desplint, in case we are doing a 4 weeks splint, 6 to 8 weeks, and 4 months, again, in case we are doing a cervical splint, a cervical root fracture splint, and then 6 months and 1 year. And again, this is a hard type of fracture that we need to see the patient after for every year until at least 5 years of the tooth age. We discussed the treatment. We have to reposition, stabilize according to the type of fracture, starting 4 weeks for apical and middle root fractures, and up to 4 months in case of cervical root fracture. The guidelines always suggest we do not remove a non-mobile fragment at the emergency visit, and also we do not start the endodontic treatment at all in all types of fractures and luxations in the emergency visit according to the latest guidelines. We used to do this in some kinds of the luxations, but nowadays we do not start the endodontic treatment in the emergency visit at all. Of course, we have to follow up the pulp condition. Most of the time in these types of fractures, when we have to do RCT or root canal treatment, we only do it for the coronal fragment. The apical fragment, most of the time, revascularizes, does not go necrotic. So you have to just use MTA for the coronal portion, or if it's a middle root fracture, for the longer upper coronal portion. Of course, again, extrusion orthodontically or surgically is always a valid option. And in very severe cases, when we cannot treat the tooth, or in patients with systemic disease, with the lack of cooperation, extraction is still an option. The guidelines suggest that a false negative response to the pulp sensitivity test is possible for several months. And this does not indicate that we need to initiate root canal treatment. We only initiate root canal treatment upon clinical signs and symptoms, as mentioned earlier. For alveolar fracture, it's a very significant fracture that you can diagnose by having a segment of teeth moving together, displaced, and most of the time causing occlusal interference. Pulp sensitivity for the segment of the teeth undergone this fracture is mostly negative, and we suggest the same radiographic investigations as mentioned earlier. CBCT and panoramic radiographs are very useful in alveolar fractures, especially if it's an extensive trauma to the face, to the maxilla, and so on. Clinical radiograph follow-up, we have to stabilize and desplint for 4 weeks. So we want to see the patient after 4 weeks to desplint, or to check the splint is still in position, the teeth are not mobile anymore after checking the occlusion. If the teeth involving the fracture line are still mobile, we have to extend the splinting more and more for 1 week and then recheck, and for 1 week and recheck, and so on, because alveolar fractures sometimes take more time than 4 weeks to fully heal. And it's very normal for the fracture line to stay painful at palpation with the fingers. We have to see the patient again after 4 months, 6 months, 1 year, and then yearly for at least, again, 5 years to make sure the teeth are still vital. In case they were vital initially, the fracture line is healing, and so on. Of course, with alveolar fractures, we might have gingival lacerations. It's sometimes caused due to accidents and complicated fractures and so on. So we might need to suture the gingival lacerations, or again, call a surgeon in case it's beyond our scope of management. Again, we never start endodontic treatment in the emergency visit, and we have to keep following up the pulp condition of all involved teeth for a very long time. Again, from the guidelines, a false negative response to pulp sensitivity is not enough to start endodontic treatment, even after several months. And again, it's very normal at the time of healing to have tenderness at the bone line of fracture. This is not an indication of a pathosis. Okay, so we have finished the fractures. Let's proceed to the luxations, which are the more intrusive and painful fractures in this age category. And most of the time, we see these luxations combined with complicated crown root fractures or complicated crown fractures with pulpal involvement. So again, we start with the mild luxative injury, concussion. Excuse me. So concussion is very regular to all of our teeth. It's very mild. Again, it can be caused by biting on a hard object or biting on some hard foods. It usually does not cause any mobility or pulp sensitivity. It does not cause a lot of tenderness to percussion, but since the periodontal ligament is affected by this mildly, you might feel some tenderness as a patient in this case. Radiographic investigations, the same baseline, the parallel periapical radiograph. And in case there are accompanying trauma, we might need to take other additional radiographs upon request. We only need to see the patient after 4 weeks or 1 year. And for the treatment, we most of the time do not need to do any treatment, or if it's a severe type of concussion, we might want to keep monitoring the pulp condition for some time. A more severe, but still mild in luxations, a subluxation, which is again below the level of luxation. The tooth is not displaced, but it is mobile in situ in place. It is tender to percussion, and there is a mild injury to the supporting structure, to the periodontal ligament. A very significant character is bleeding from the gingival crevice in this case. And pulp sensitivity most of the time is initially negative, indicating a transient pulp damage, because the blood supply might get cut upon the blow or the trauma. For the radiographic investigations, we might need one parallel periapical radiograph again for the baseline, and we might need 2 additional radiographs at different angulations. Sometimes we need to use an occlusal radiographic investigation, but again, this is dependent upon when we can achieve a diagnosis and how severe is the subluxation. We do not need to do a treatment most of the time, but if there is a lot of pain upon biting by the patient or the mobility is too much, we can splint for 2 weeks. And of course, upon splinting, we have to monitor the pulp condition. We have to see the patient after 2 weeks to desplint, and after 12 weeks, 6 months, and 1 year. Now we're talking again, we have the extrusion, the intrusion, the avulsion, and the lateral luxations. These are the most severe types of luxative injuries, especially intrusion, lateral luxation, and avulsion. Extrusion, again, is the displacement of the tooth outside the socket in an apical direction, in an incisal direction, away from the apex of the tooth. And this is what makes this kind of luxation less severe, because most of the time the bone is spared, and the surrounding tissues inside the oral cavity are not so much affected. But since the blood supply is cut, we get a pulp sensitivity test of negative. And of course, the tooth is mobile because most of the supporting periodontal ligament gets cut in this kind of luxations. On the radiograph, we can see a longer tooth than the surrounding teeth. Again, we might want to take one parallel periapical radiograph as a baseline and 2 additional radiographs in case we cannot get a diagnosis or even use an occlusal radiograph. For the first time, the guideline mentions local anesthesia. We have to anesthetize this patient because this kind of trauma is very painful to reposition without local anesthesia. So before repositioning, we have to anesthetize the patient, reposition, and splint for 2 weeks, like we mentioned in subluxation, in case we were going to splint. And again, with the splinting, we have to monitor the pulp condition. If the pulp becomes necrotic, we have to initiate root canal treatment only upon symptoms. And most of the time, this happens with teeth with closed APCs. Teeth with open APCs have the capability to revascularize even in the worst scenarios. So again, we have to see the patient after 2 weeks to remove the splint, and then the same follow-up routine for the earlier luxations. For the first time, again, the guideline mentions using an intracanal medication, example, calcium hydroxide, because these kinds of luxations causes an external inflammatory root resorption, and if it develops in very young kid with open APCs in their teeth, the damage gets very fast to the extent that they can lose the tooth to root resorption in 2 to 4 weeks. So upon following up radiographically, if we see signs of external root resorption due to infection, we have to use calcium hydroxide as an intracanal medication and reapply it until root resorption stops on the radiograph. Or else we will be losing the tooth, especially in the growing phase, very rapidly. Calcium hydroxide has a very alkaline pH, and that's why it stops and antagonizes the acidity of the infection. So for extrusion, splint for 2 weeks. For lateral luxation, we mention that the tooth is displaced, but in a lateral direction, not the same direction of the long axis of the tooth. And most of the time, compression or fraction of the alveolar bone is accompanied, and that's why when we have to reposition and splint, we mention splinting for 4 weeks, not just 2, due to the alveolar affection that is most of the time happening with lateral luxations. This tooth is an immobile tooth. It's actually driven into the bone, so it does not move. Sometimes we have to reposition it digitally, remove it from its position and reinsert it into the right position in the bone. Upon percussion, it gives the same high metallic sound of ankylotic teeth. And due to the crushing that happens to the bone, to the periodontal ligament, the pulp sensitivity is mostly negative. And on the radiograph, we can see one portion of the periodontum with widening and the other portion that the tooth has crushed. We do not see the periodontium at all. So that's why we have to see multiple angulations on the radiograph to make sure we can diagnose the fracture line, the luxation line. So as we mentioned, for the treatment, we have to reposition and splint for 4 weeks this time. Of course, with the splinting, again, we have to monitor the pulp condition, especially again with the teeth that has closed apices. And if on the following up radiographically, any kind of symptoms to inflammatory root resorption has initiated, start injection of calcium hydroxide intracanal to stop the effect of external inflammatory root resorption, which is a very rapid and aggressive encounter that happens at this age category. Follow-up routine again, 4 weeks for desplinting, 2 weeks for endodontic evaluation. So most of the time we do not again take the decision of the endodontic treatment at the emergency visit. We have to wait either for splinting, for making sure the tooth is in the right position before initiating the endodontic treatment, or for given some time for reassessing and choosing whether to go through the endodontic treatment or not. So 2 weeks for endodontic evaluation, 4 weeks for desplinting, 8 weeks, 12 weeks, 6 months, and 1 year, and then yearly for at least 5 years after that. And again, a false negative response to pulp sensitivity, even after several months, does not guarantee that the tooth is necrotic. So, extrusion, splint for 2 weeks. Lateral luxation, splint for 4 weeks, of course, with following up and monitoring the pulp condition. Intrusion, again, this is a displacement of the tooth into the bone, so we expect the bone to get crushed and to get some kind of damage. That's why when we talk about splinting, in case we are going to splint in intrusion, we're going to discuss it in details now, but again, if the bone is involved, we think about 4 weeks instead of 2. For intrusion, if you remember in primary teeth, we mentioned that we just leave the teeth for spontaneous eruption, always. In permanent dentition, it's a little different because we do not have the capabilities of the malleability of the bone and the healing power of the very young kids. So we have to think about what is the decision given the maturity of the tooth. If the tooth is immature, meaning with incomplete roots, we have to allow spontaneous re-eruption independent on the degree of intrusion, however the intrusion was. If it were very deep intrusion, still give it at least 4 weeks before taking the decision of interfering orthodontically or surgically. So 4 weeks of doing nothing as long as we have an open apex, just watching. If not, if after 4 weeks we do not have, of course, we have to take baseline photographs to compare and x-rays. If after 4 weeks we do not have any movement of the tooth, we have to start interfering with orthodontic extrusion and give it a time, again, because we have a very high initiative of having the tooth move when we talk about open apices. So we monitor the pulp condition after the orthodontic extrusion, which is considered a mild type of extrusion, but still it can cause some kind of necrosis. And also because we have an initially traumatized tooth, so we have to keep monitoring the pulp always. And most of the time, with open apices, spontaneous pulp revascularization occurs. If not, if pulp necrosis appears clinically, we have a clinical sign or symptom of pulp necrosis, or on the radiograph, we can see inflammatory root resorption signs. We have to start as soon as possible with calcium hydroxide injection, as mentioned earlier. So this is with open apices. We wait until 4 weeks, and then we initiate orthodontic extrusion. In teeth with complete roots, we allow, again, spontaneous re-eruption, but only not independent of the degree of intrusion, as I mentioned earlier. This time we have to see how intruded is the tooth. And we can measure how intruded is the tooth given the contralateral tooth. For example, if we are talking about the right central incisor, we have to measure how intruded it is in respect to the left central incisor. If it is intruded less than 3 millimeters, we still have hope. Even if it is a closed apex, we still have hope that the tooth can spontaneously re-erupt up to 2 months of noticing or watching and waiting. If not, we have to initiate either surgical or orthodontic extrusion. And with surgical extrusion, again, this is exactly as you are extracting the tooth. So you have to resplint the tooth for 4 weeks. And we mentioned 4 weeks because of the expected bone trauma in this kind of luxation. So if the tooth is intruded below 3 millimeters, we're going to wait for 8 weeks and then initiate surgical or orthodontic extrusion. Surgical extrusion is faster, but orthodontic extrusion is milder. It causes less damage to the bone, to the pulp, and so on. Teeth intruded from 3 to 7 millimeters, we have to choose between surgical and orthodontic extrusion without any further waiting. This teeth will not re-erupt spontaneously at any cost. And if the teeth are intruded beyond 7 millimeters, the only hope we have is in surgically repositioning the teeth and resplinting. 7 millimeters is too many millimeters for a tooth to move by itself. So if you have a tooth intruded in respect to the collateral tooth, the contralateral tooth, less than 3 millimeters, give it some time. If it is a closed apex, give it some time for 8 weeks. And then you have to start doing the extrusion. If the tooth is intruded 3 to 7 millimeters, you have to start immediately with surgical or orthodontic extrusion. If the tooth is intruded beyond 7 millimeters, only surgical extrusion will be effective in this case. And you have to splint for 4 weeks with surgical extrusion and follow up for the pulp condition. And most of the time with surgical extrusion, the pulp will go necrotic because, again, this is exactly like extracting the tooth. And of course, if the signs, again, of inflammatory external root resorption appears at any moment, you have to start RCT, root canal treatment, with calcium hydroxide dressing for the schedule of 6 weeks and reapplication. And we're going to discuss this later. Until the signs of root resorption disappears completely on the radiograph. So, extrusion, lateral luxation, intrusion. Now we get to the most severe luxative injury, which is avulsion. In avulsion, the best and the only treatment we have for a permanent tooth, with all kinds of scenarios, with all kinds of expected prognosis, is the reimplantation. But sometimes reimplantation is not indicated in patients who cannot sustain a replanted tooth, when a tooth might be a hazard to the kid. And this most of the time happens with very uncooperative patients, with patients with cognitive impairments requiring sedation, like patients with mental impairments, aggressive spectra of autism, and so on, ADHD, and so on. And sometimes with severe medical conditions, such as cardiac conditions or severe immunosuppression. We do not want to put a tooth with dirt and bacteria and so on back into a socket of a child who is immunocompromised. Also, if the tooth initially was very carious or had severe periodontal disease, there is no point to put it back. But other than that, replantation, again, is the only option we have for a permanent tooth at this age category, until we can go through a better treatment with an implant, a resin bonded bridge, a normal bridge, and so on. And this won't be applicable before at least 18 to 19 years of age. So the most important point in treating avulsions is the expectations of the parents, especially when we have very bad prognosis for avulsions. And this happens most of the time. The bad prognosis happens when we have closed apices for the teeth, and when the teeth has fallen out of the oral cavity and stayed in the dry media for a very long time, more than 1 hour. And by dry media, I mean by not putting the tooth back into an osmolality acceptable media for the periodontal ligaments to stay viable. And we are going to discuss what kind of media we are speaking about. But if the tooth just falls on the floor for 1 hour, you have to put it back if the immunity and the medical condition of the child allow, but we have to tell the parents that most of the time this tooth won't sustain for a very long time. It will get necrotic, it will get ankylotic, external root resorption might get initiated, and this tooth can be lost. But when, we never know, we try to put our efforts and do our best to keep this very precious teeth in place. Okay. So this is very important education. We as dentists, especially pediatric dentists, have to provide for our community on the issue of avulsion, because this can save lives of teeth for very young kids. And most of the time, this happens a lot at schools, at playgrounds, during sports, and all of the time, people do not have enough, maybe guts or enough education to put the teeth back in their position. Most of the time, if you put it back on the spot, you saved a lot of hassle for the tooth and the kid, and also the parents. So we have to educate teachers, maybe sports teachers, clubs, parents, of course, and all kind of caregivers on how to treat avulsed permanent teeth when this happens. Of course, again, the first question we have to ask when they call you and they tell you my patient has knocked out their tooth, you have to ask, is it a primary or a permanent tooth? And most of the time, you can guess the answer from the age of the patient. If the patient is above 6 years of age, most of the time it is a permanent incisor. If not, you have to discard the tooth after making sure it was a primary tooth, because we do not replant, again, we do not replant primary teeth into the oral cavity to avoid causing further damage to the successors. So at first, when you see someone who needs the first aid for avulsed teeth, you have to keep calm. You have to tell them you have to keep calm. You have to find the tooth, pick it from the crown. Do not handle the tooth from the roots, because the roots hold the very precious periodontal ligament cells that we want to keep viable for as most as we can. And then attempt, after maybe cleaning the tooth with running water if it is applicable. If not, we have the milk, the saline. Of course, milk is best, is much better than using water for cleaning. We can agitate the tooth in milk and put it back into the jaw. Make sure that the buccal surface of the tooth is looking buccal and the palatal surface of the tooth is showing palatal, and ask the kid to bite on the tooth with a cotton, a handkerchief, whatever is available to them, a napkin, and then move directly to a dentist. If not applicable, if the parents are scared to put the tooth back, if the kid is unconscious and they cannot put the tooth back due to the risk of aspiration, for example, or so, they can put it in a media. And this media can save the viability of the periodontal ligament for quite some time, not a very long time, but this is much better than leaving the tooth out in the dry air. The best media is skimmed milk, according to the guidelines of the American Academy of Pediatric Dentistry, followed by Hank's balanced salt solution. And Hank's balanced salt solution should be available in first aid kits and pharmacies and so on. If not, if we do not have milk, we do not have HBSS, we can use the saliva of the patient after asking them to keep spitting into a glass cup until the spit can cover the surface of the tooth. Earlier guidelines of the AAPD asked if we can put the tooth back into the buccal vestibule, for example, in the oral cavity to keep it wet, but due to the hazard this can hold, especially with a traumatized kid, we do not know how traumatized the kid is, if the conscious of the kid is full or not, if some kind of head trauma has happened or not. So it's better to spit into the cup and put the juice in the saliva instead of putting it inside the oral cavity. And again, we have to run for a professional immediately. The International Association of Dental Traumatology, the IADT, provides posters under the name of Save Your Tooth in different languages. Maybe some Ethiopian pediatric dentist would like to take a chance to translate this poster into the used languages in Ethiopia, the Amharic or so. And also there is this mobile application provided for free by the International Association of Dental Traumatology. It is named Choose SOS. And there are quite a lot of applications like this one. This poster is very beneficial. It gives short and funny instructions to the parents, to the kids, and to their teachers on how to deal with avulsed permanent teeth, how to put them back until they can reach a professional. So the choice of treatment in avulsion, again, is related to the maturity of the root, how open or closed the apex is. Open apices, again, have better chance in revascularizing and in getting the tooth back into function. Also, the condition of the periodontal ligament, and this depends upon, or the viability of the periodontal ligament cells, and this depends on how much time the periodontal ligament cells have been in dry air. Okay, most of the time after 30 minutes, maybe 20 minutes in some literature, the periodontal ligaments are non-viable. So we have three scenarios of the periodontal ligament cells. Either they are viable in case only 15 minutes at most has passed after the tooth has been knocked out of the socket in dry air. They might be viable but compromised if they have been put, if the tooth have been put into a storage media, the ones we mentioned, like skimmed milk, Hank's balanced solution, saliva, saline, and the worst is running water, but it's better than dry air. Okay. After maybe less than 60 minutes, but after 15-20 minutes, if the tooth has been put into the media after maybe 15 to 20 minutes. So most of the time, in this case, the PDL cells will be viable but compromised, not in their best health. And the worst scenario if the periodontal ligaments are totally non-viable, and this happens when the periodontal ligaments upon the tooth root has been exposed to dry air for more than an hour, a 60-minute duration. In all three scenarios, we are going to replant the tooth and splint it in position, but these timings give us an initiation on how long the tooth will stay in place before resorption, ankylosis, or pulp necrosis will happen. But in all scenarios, we have again to put, this is the only treatment we have for avulsion, to put the tooth back and splint it for 2 weeks, unless there was some kind of accompanying bone fracture. So in this stage, we have to splint for more than 2 weeks. So we have two scenarios with avulsion. Whether the parent or the guardian has succeeded to replant the tooth at the site of the injury before reaching the dentist, or they fail to, and they have the tooth in a media. So with the first scenario, of course, this is a better scenario. When they reach you as a professional, what do you have to do? You have to clean the injured area with chlorhexidine gluconate, for example, water or saline, and make sure the tooth again is buccal to buccal, palatal to palatal, is on the same level of the contralateral tooth, and leave it in place except if the tooth is malpositioned and needed to be corrected, like a little rotated, for example, with digital pressure. Okay. Most of the time, again, this is a very painful procedure, so you might want to administer local anesthesia. And if the tooth if the teeth were planted in the wrong socket, for example, a lateral tooth was knocked out, a lateral incisor together with a central incisor, and the parent implanted the lateral in the socket of the central and the central in the socket of the lateral, you have to interfere and remove the teeth and replant them in the right position. Only if this happens before 2 days after the traumatic dental injury. After 48 hours, it's useless to remove the teeth and expose them to more trauma. You will be cutting more of the periodontal ligament, and this kind of complicated trauma you inflicted will have a very bad prognosis on the long run. So after 48 hours, do not interfere, even if the teeth are in the wrong position. Just leave them be. And again, we have to stabilize with avulsions. We stabilize all teeth for 2 weeks unless we have an accompanying bone fracture or other fracture. When it comes to the splints, most of the time we splint with composite and wire, like in the photo. And the wire thickness, the wire diameter should not exceed 0.4 millimeter, and we have to bond from the away to the close tooth. يعني start away from the teeth, avulse, and then bond, and when you reach the position of the avulsed tooth, make it the last piece of composite to be bonded to the tooth surface to make sure that the tooth will be in the right position. We also can use some other kinds of flexible splints, for example, like nylon fishnet. But nylon fishnet is considered very weak. So most of the time, if we have very short permanent teeth at like 7 or 8 years of age, when the teeth are still not mature, we do not like to use nylon fishnet line because it does not stabilize the teeth in position. But it's still, again, a viable option, and it's a more aesthetic than that of the composite and wire. Also, the question of whether to use the splint on the labial or the palatal surface. The guidelines suggest to use the splint on the labial surface to avoid causing occlusal interferences to the kid, and also in case we want to initiate an endodontic access. Most of the time we do it from the palatal surface unless we had caries on the buccal surface, severe caries. So it's better to keep the splint buccal. So the difference between what to do after the splint in a closed versus open apex. With a closed apex, most of the time we have to initiate the endodontic treatment before removing the splint. Of course, if we have a gingival laceration or, again, a complicated bone fracture, we have to extend the splinting and make sure we suture the gingival laceration. And again, with the closed apex, we have to initiate the root canal treatment before removal of the splint or within 2 weeks. But again, for the open apices, we have the hope for spontaneous revascularization. We do not have to start endodontic treatment unless, again, signs or symptoms of necrosis appear, or if we have a radiographic evidence of the development of infection-related inflammatory root resorption. At this point, we have to interfere, do an access, remove the pulp, and inject calcium hydroxide into the tooth. And after splinting the teeth, repositioning them, splinting them, and following up for the pulp condition, we have to administer systemic antibiotics if needed upon the clinical expertise of the operator. Again, we have to check for the tetanus vaccination. Sometimes we need a booster dose when the kid have passed 5 years of age without taking a booster, and they had an outward fracture, like in a playground, like in a dirty place, they have to recheck the latest tetanus booster. And of course, we have to give the parent and the patient post-operative instruction. We have to prescribe painkillers in case they are in pain, ask them to brush their teeth twice daily with a soft brush and avoid inflicting on the traumatized tooth. Use chlorhexidine gluconate for cleaning and for wiping around the splint and so on to keep the place clean and facilitate healing. And of course, follow-up is mandatory in all luxative injuries. So this was the scenario in case you already got the patient with a replanted tooth. If not, if the tooth has been kept in a physiologic storage media, example milk or Hank's balanced stool solution, and we have the patient in your office, whether before or after 60 minutes, again, it won't differ. You have to replant the tooth, but before 60 minutes or even 30 minutes, you can expect a better prognosis, especially with an open apex. After 30 to 60 minutes, you do not expect a lot to the tooth life, especially if the tooth has, again, a closed apex. At that time, you have to clean the tooth, clean the socket, and again, replant, stabilize, and so on. So if there is a visible contamination, you have to rinse the root, most of the time agitated in the balanced media, and then put it back after cleaning the coagulum from the socket, making sure the socket is clear enough so that you can put the tooth back to its previous position. Make sure the position is radiographically and clinically acceptable, and start splinting the tooth. And if the tooth is with a closed apex, again, we have to initiate endodontic treatment before 2 weeks, before removal of the splint, or before 2 weeks of time. And if it has an open apex, just hope for the best unless you get signs and symptoms. So, conclusions. I love this table by the AAPD because it has all the times for splinting according to the latest guidelines in both primary and permanent dentition. So let's recapitulate. In primary dentition, we only suggested splinting in 3 scenarios: root fractures, lateral luxations, and alveolar fractures. And in 3 scenarios, 4 weeks of splinting, and only upon cooperation and appreciation from the side of the patient and the parent, if you remember. When we talk about splinting in the permanent dentition, we mentioned 2 weeks for subluxation and extrusion because these 2 types of fractures, these 2 types of luxations, most of the time, the bone is not involved. So as long as we do not have alveolar involvement, we do not need to extend the splinting beyond 2 weeks. Also for avulsion, the latest guidelines only offers 2 weeks of splinting versus 2 to 4 in the old scenarios. We only extend if we recheck the occlusion after 2 weeks and we find that the tooth is still mobile. But other than that, if we do not have an accompanying bone fracture, 2 weeks for avulsion in all scenarios are enough. For other fractures or luxations involving the bone, like the intrusion, the lateral luxation, and also the root fractures, we extend the luxation together with alveolar fractures to 4 weeks. And in the scenario of cervical root fracture, we can extend to 4 months because this has the worst prognosis and the mobility of the fragment is very likely. Again, when we speak about when to initiate endodontic treatment, especially with external inflammatory root resorption, because this is very commonly happening in severe luxations in permanent dentition. So start the root canal treatment, especially in closed APCs, as soon as possible whenever there is a radiographic sign of inflammatory root resorption. Calcium hydroxide is the best intracanal medication, better than corticosteroids and triple antibiotic paste or any antibiotic paste according to the guidelines. We start with injecting calcium hydroxide for 3 weeks, and we shall replace it every 3 months until the radiolucencies of the resorptive lesions disappear completely, and then we can proceed with RCT with, for example, gutta-percha or MTA or whatever. Also, the guidelines suggest that we always keep the calcium hydroxide below the level of the cervix, below the crown, because this medicaments cause discoloration to the crown of the teeth, and this is an aesthetic zone. For drug use, topical antibiotics are not guaranteeing any better prognosis. We used to have this in the guidelines in the older days to soak the teeth after avulsion in topical antibiotics, but nowadays the guidelines suggest that human studies have failed to demonstrate any improvement upon soaking the teeth in topical antibiotics. But for the systemic antibiotics, guidelines have recommended that they can actually, yes, prevent infection-related reactions, including infection-related root resorption in avulsions, especially due to the mix of bacteria and contamination from the oral cavity, the storage media, or the environment. Of course, the storage media won't be sterile. So upon the clinical expertise, if you need to use a systemic antibiotic after avulsions, do. According to the guidelines, it's safe to do. And of course, again, refer the patient for the tetanus booster evaluation in case avulsion happens in a dirty environment or an open environment. For the follow-ups, again, for open APCs, most of the time the scenario goes better than closed APCs, but the problem with open APCs, the capability of these teeth to accept a lot of blood supply, undifferentiated mesenchymal cells, and osteoclastic differentiation, and this can happen very fast, including causing inflammatory infection-related root resorption. So again, if you see the smallest sign of root resorption on the radiograph, start injecting these teeth with calcium hydroxide and keep replacing the paste until you no more you no longer see this on the radiograph, and then you can proceed with the final root canal treatment restoration. Again, I cannot speak enough of how important is using a DSLR camera in your practice, especially with traumatic dental injuries, together with a macro lens and a good flash. You can use this for initial documentation, for follow-ups, and for comparing the baseline photos with the follow-up photos to check the soft tissue healing and to educate the patient about how far they have come. To assess if discoloration occurs in teeth, especially in teeth with blows or with severe luxative injuries, and also teeth that have received discoloring medicaments like calcium hydroxide or MTA, for example. Also, you can see the re-eruption levels of an intruded tooth, and you can see the development of infraocclusion or ankylosis in a growing patient, and you can quickly interfere with, like, for example, decoronation or root submersion to avoid going through the hassle of losing the vertical dimension of the bone, which is a very precious bone in a very precious area. The guidelines always goes for the dental rubber dam during endodontic treatment, especially with these patients who might be moving a lot of times in pain and not stable. But the guidelines suggest using a dental floss, like, for example, a part of the rubber, Teflon, or any other cords to stabilize the rubber dam instead of using the clamps, the metal clamps, to avoid further traumatized teeth and to avoid inflicting more pain on an already suffering child. So use the rubber dam, but only make sure you can use different methods to avoid causing more pain with the clamps of the rubber dam. So these are, again, the references, the guidelines of the American Academy of Pediatric Dentistry for 2025. And again, I'll be very happy to receive anything from your side, discussions, invitations. I'd like to get involved in anything with the audience here. Looking forward to meeting you again, and I hope this was of some benefit to you. Thank you so much.